Okay, so let's continue to overview the ABCD applications. So after A, so after the enhanced management of airway with point-of-care ultrasound, let's now to start overviewing the overall breathing, respiratory management enhanced by ultrasound. Already Dr. Cheng have introduced some concepts, particularly about the ventilation signs, like the lung sliding, proving the movement of the pleural, visceral pleural on the parietal pleural. So proving the movement of the lung. Movement of the lung doesn't mean necessarily ventilation of the lung, but most of the time means it. Okay? So you could have a lung moving because the other lung is being ventilated, and the lung, maybe the right lung, could be not ventilated properly but still moving. But most of the time, when you see the sliding sign, that means lung visceral pleural mobility, it means ventilation of the lung. Okay? But we'll see systematically this part in this lecture, that will first resume all the main findings. Then we'll try to compose the sonographic findings in different pathology syndromes, and then in different clinical scenarios. But this will be given to you lecture by lecture, and you will have the final picture tomorrow. So let's try to be systematic on this application. So here you see again the ABCD compound of techniques, and you see that lung ultrasound is here. But obviously the respiratory assessment of the patient is not only an issue of lung, it's related with the airway and is related to the whole hemodynamic system. So if our patient is getting hypoxic, lung ultrasound can give us an answer, but maybe that the answer is coming from the airway assessment or from the full hemodynamic assessment. Okay? So again, we'll see this clinical approach better tomorrow. In this lecture, let's focus just the organ, lung, and how ultrasound can provide us information about this department. So you see here are the main sonographic patterns that we are going to check. Yeah, I'm waiting for the plug extension before running out. And you see that here we have general applications, the more traditional, like the pleural effusion, the consolidation. You see here the alveolar interstitial syndrome or the pneumothorax. We'll systematically overview together how to recognize these different sonographic syndromes. Whatever we are mentioning about lung ultrasound in this course is part already of these guidelines that were written and published 2 years ago in the Intensive Care Medicine Journal, after 3 years of work, where a consensus of experts, I was also part of this steering committee, overview the world literature about lung ultrasound, and together with methodologists graded all the literature and graded the consensus around the different literature outcome. And so this is the compound of recommendation and guidelines coming out from this consensus. So whatever we'll be mentioning in this lecture and the next ones about the lung ultrasound is today based on strong evidences, and this has to be considered a best practice already. For example, after a thoracentesis or a central vascular access, to rule in or rule out a pneumothorax, and a pneumothorax with ultrasound is not only an option, it's a must, because the evidences are telling us that it is very much more accurate than X-ray to rule in and rule out in a timely manner a pneumothorax. So again, we are talking not anymore of an innovation, of an optional use, but of a best practice that we should integrate into our clinical practice. Where lung ultrasound is making really a difference in our practice, I'm using this paper among many of similar outcome that is studying and matching the performance of ultrasound in terms of specificity and sensitivity against X-ray and the traditional clinical examination with a stethoscope. And you see that, thank you very much, and you see that in terms of specificity, a traditional approach with stethoscope and X-ray will be very performant. But in terms of sensitivity, it's very, very poor. What these numbers mean? For example, pleural effusion. You see from this number that if you, with a stethoscope or your clinical examination and or the X-ray, say there is pleural effusion, you are usually right. So there are not a lot of false positives. Or for example, here you see pulmonary edema, for example, or RDS, things like that. If with the X-ray or a clinical examination you say there is a pulmonary edema, you are usually right. So you don't need of lung ultrasound to perform better in terms of specificity. But if you see the sensitivity, it's a disaster, because you see, for example, that between among 100 patients with pleural effusion, 60% will be negative, but false negative. Or with a stethoscope, 60% will be negative. What about, for example, pulmonary edema? 40% of 100 patients with something like pulmonary edema will be negative. So in our clinical practice, with traditional approach, we have low false positive, but we have a lot of false negative. And this in practice, what does it mean? That many patients will be misdiagnosed, so maybe that will be discharged while they will have still some problems, for example, small amount of fluid. Or you are obliged to wait the amount of fluid to be big, the pulmonary edema to be severe, or the pulmonary consolidation of pneumonia to be big to be diagnosed. So the traditional approach is usually determining late diagnosis and less accurate diagnosis. Let's see what ultrasound is doing. Good specificity, you see, similar to the other. So ultrasound is not making you more specific than usual. But look at the sensitivity. 92, 93, 98 is huge. So what does it mean? That even a small amount of fluid will be detected by ultrasound. Even a pulmonary edema on early stages will be detected. Or even a very small pneumonia, provided that is superficial, will be detected. So the major impact of lung ultrasound in your clinical practice is about less false negative, that practically means earlier diagnosis, more accurate diagnosis, and then means less morbidity, less mortality, and less cost for our patient. What about the technique? You see that essentially lung ultrasound is a surface technique, because if the lung is full of air, like physiologically it is, air is a barrier for ultrasound, so you cannot see from a side to another of the lung like the X-ray, but you need to explore the lung on all the surfaces, okay? Then in the workshop this afternoon I will give you more practical advices about how many windows, in which conditions to look at. For example, if you are doing a CPR, your question is not about a localized pneumonia, but your question, your clinical question will be, is there a pneumothorax, a tension pneumothorax? Is there a massive pneumothorax causing this cardiac arrest, okay? A presentation, or PA, cellular electrical activity, maybe presentation to act on it. So just the windows are enough for me to say no tension pneumothorax, no massive pneumothorax. I don't need 10 windows. But if my question is dyspnea, severe dyspnea could be then a large pneumonia, pulmonary embolism, asthma, etc., etc. So I will need at least 6 windows on the hemiclavian line, on the anterior axillary line, on the posterior axillary line, at least 1, 2, 3, 4, 5, 6, because most of the causes of dyspnea will be enough large to be detected by this approach. But if my question is coming from fever, why my patient has fever? Then I can have even a 1 centimeter diameter of pneumonia causing fever. Do you agree? It will never cause dyspnea, major dyspnea, or hypoxia, or cardiac arrest. But fever, yes. Then 6 windows could not be enough, because if the focus lesion that I'm looking for is more like this, causing fever, so my question is coming from why there is fever, and I'm using ultrasound to detect it, then it's better that I do slices of the lung, not windows, because otherwise I will miss the little pneumonia. It's clear? So the number of windows and the position of the probe will depend by what I'm looking for. But essentially I try to highlight to you at least the 3 approaches. 1 extremely emergency, 1, 2, the highest and the most independent one. Then 6 windows for most of the causes of dyspnea or hypoxia. Then when you're looking for very focused and localized lesion, you have just to check thoroughly the surface of the lung, and you have time to do this, because it's another kind of setting. You can have a longitudinal and transversal view and all the oblique scanning, but at least for most of the windows, you should have at least these 2 kind of look. And you should always remember that air and the water distribution in the lung will depend on gravity. Why this is so important? Because all the ultrasound images are born by water or air, or a mixture of the 2. So the degree of air and water that you will find will create a different imaging. So it's very important that you always think what you are expecting under your probe, and then you could better read the lung ultrasound image. This is a basic imaging of a transthoracic longitudinal view. Longitudinal means, okay, with a craniocaudal direction. So the 2 ribs will be cross-matched like that. So I will have a craniocaudal orientation with superficial and deep orientation. This is skin, the subcutaneous layer. Here I have the muscular fascia. Here I have the thoracic muscle. It could be a major pectoral muscle here. Then here I have one rib and the other rib creating shadows. The intercostal muscle, and this is the pleural interface. And whatever is below, it's an artifact. So, the first target of your image recognition will be at least to identify what is the pleural line. Because whatever is above will be pertinent to the chest wall, whatever is below will be representing the lung and the pleural cavity. It's important that you start thinking to the fact that whatever is above the pleural line is usually a real image that is just what is really existing. If you are a pathologist dissecting these layers, you will find exactly these layers with this size and this shape. Whatever is below the pleural line with an aerated lung is artifact. What you see here is not lung. It's generated by the interaction between ultrasound and the air met at this level. Okay? So, the lung ultrasound approach is an issue of recognize not only anatomical images, but also artifactual images. So, what is the systematic approach to the lung ultrasound image? First of all, you should think, is there an indication of using lung ultrasound, yes or not? Because that is the key point, the starting point. It is useful what I'm doing or not, or I'm just losing time in emergency. So, first of all, is my examination, lung ultrasound examination indicated? I have a clinical question that is appropriate. So, why there is fever? Why there is chest pain? Why is there is hypoxia, dyspnea? All of this is appropriate, is an indication for using lung ultrasound. Once that you have the indication, you start generating and acquiring the image. So the first target of yours is to acquire a quality image, an image of good quality. Okay? So before starting to interpret the image, please, your first question will be, second question, after, is there an indication? Yes. Is my image, okay, properly acquired? Okay? What is to be properly acquired? Am I using the appropriate probe, with the appropriate machine, with the appropriate setting? Is my patient in the appropriate position? Did I get the consent of the patient to do this? Etc., etc., etc. So, all circumstantial and technical points that would make your image appropriate, adequate. Is the depth of the image is appropriate, the direction, the brightness, the focus, the orientation of my image. So all the things that were overviewed by the previous lectures about physics, about the technique, is all of that appropriate? Is the image of quality, of enough quality for me to interpret it? Yes or no? Because if it's yes, you have not to write usually, you move forward. But if it is not, you have to write down that the examination was limited for this. And then or you redo the examination, or you stop doing the examination, you say ultrasound is not feasible. That's it. Or you try to interpret it, but your reviewer or your colleague or the patient or whoever reading your report should know what were the conditions under which you have performed your interpretation. It's okay? From now on, I will not insist anymore on the quality, but this is a crucial starting point. Let's now think about interpretation of the image. You will always have at least 3 steps in the interpretation. The first is sonographic. So you should recognize sonographic signs like A lines, B lines, C lines, lung sliding, lung pulse, etc., etc. How many minutes do you have? 5?
Yeah.
I will try in 5, but I would need at least 10. So let's try to see here in this image how all the sonographic findings are formed. Here is the ultrasound beam coming through the tissues and being reflected by different interfaces. The more the interface is perpendicular and the more there is a difference of impedance between two adjacent tissues, the more the reflection will be of high intensity. So what is brighter here means a higher level of reflection, determined both by the angulation and by the capacity of reflecting of that interface. What happens if different points at the same depth have a similar reflection capability? Then your eyes will recognize something like a structure. These are several bright points representing an hyperechoic line, for example. And you see that a little bit deeper, there is another interface reflecting, composed by many, many dots, you see here, brighter than what is adjacent, and will allow your eyes to recognize other linear structures. Then you will have other interface with different orientation that will reflect a little bit weaker, with a signal that is fading, that will have this kind of representation. So you see that now we start recognizing with our brain certain sonographic line and structure that are recalling as anatomical structure. So for example, this hyperechoic line at about maybe half centimeter, what could be anatomically? If it's in me, cannot be the rib or the pleural line, maybe in a very thin man. So this is the muscular facet, for example. And what about this line that is about 2 centimeters? What could be? The pleural interface. What about this? The costal interface. So you see that looking at the sonographic images, you should start the second step of interpretation, that is the anatomopathological interpretation. So this is just an hyperechoic line. This is another hyperechoic line that I will call a pleural line. What are the anatomical components of the pleural line? Is the parietal pleura plus the visceral pleura plus the subpleural air that is reflecting itself. So what you see here bright is actually a structure composed by 3 components: parietal pleura, visceral pleura, subpleural air. So what you see here is pleural line, sonographic interpretation or description. Meaning what? These 3 anatomical structures. Okay? What's happening in this image? That beyond the costal profile that is hyperechoic, there are hypoechoic, dark areas, shadows, acoustic shadows, representing what? Nothing. They are artifacts because the energy is absorbed by the bone, calcified bone. So what you see here is not liquid, it's not fluid that is not reflecting. It's nothing because no energy is getting there. So you see that what is black sonographically doesn't mean always fluid or doesn't mean always nothing. You should interpret it. So if this area is beyond a cortical line, this will be just a shadow. So no anatomical meaning, no pathology meaning. If this black area is here, not beyond the bone, the same black area could be fluid, intrapleural fluid, or could be a lung consolidation. So alveoli full of fluid. That's why it's so important to be systematic. First, sonographic interpretation. Hyperechoic line, hyperechoic area, hypoechoic, and then recognize the sign. And then to attribute anatomical meaning and anatomopathological, physiopathological meaning to the different structure. What else? Some of the waves are not just reflecting once, but they are being reflected by the skin and then again by the pleural line before coming back to the machine. So the machine will have signals coming double the time, so delayed by double the time. You see, 1, 2, and they are coming back. So the machine will represent dots and lines deeper than the pleural line, but not coming by a structure that is reflecting, but just because there is a reverberating effect that is creating a mirror. So what you see here is an anatomical structure. What you see here does not exist. It's just an effect of this reverberation. We'll call this pleural line, composed by visceral parietal pleura and subpleural air, and we'll call this line A lines. A lines, just to help you to remind, could be something like, to remember, could be something like air line. Why? Because these lines refer directly to the presence of air here. And what you see here, all these sub-lines here, are just the mirror image of the chest wall, like a mountain reflected on the lake. Okay? What you see here is just the mirror image of the chest wall. So when I see A lines or the mirror image of the chest wall, I know that there is air. What kind of air? Alveolar air of a dry lung or intrapleural air of a pneumothorax? I don't know from this picture. I need other signs that we'll review in a while. Okay? So this is how we first have the image divided in three sectors. The pleural line will divide this in the, you see, extrapleural sector, the pleural line itself, and the subpleural sector. Let's see sector by sector what we should look at based on this basic course. First of all, let's have a look to the external part of the image. So what is external to the pleural line? Okay? I think that any of you is getting confident of that. First of all, with the basic skills, we can recognize these hyperechoic lines. You remember what Dr. Cheng showed you before in the neck with the subcutaneous emphysema. You saw vertical hyperechoic lines that will call from now on E lines. They stand for emphysema lines. Okay? So vertical hyperechoic lines arising from the chest wall sector towards the bottom of the image will be named E lines. So sonographically you will report E lines in the explore region, sonographic diagnosis. What is the physiopathological diagnosis? Suggesting emphysema, subcutaneous emphysema, okay? What is the clinical diagnosis? Then it depends by the original question. Maybe confirming a tracheal lesion, confirming a pneumothorax, confirming a gas gangrena development of a certain infection site, confirming a damage, okay, of the lung, of the bronchus, etc., etc. Dr. Cheng, I know that I'm out of time. Can I go still 5-10 minutes?
Okay, of course, 5 minutes you go.
5 Italian minutes, okay? So, what else? In the chest wall sector, you could also see an interruption of the cortical line in this transversal view, suggesting fracture. So sonographically, you will see a step in the cortical line. So this is a sonographic description, suggesting a rib fracture, okay, as anatomopathological description. Let's now focus the pleural line sector. You should look first at the anatomy, the morphology, sorry, of the pleural line, and then to the movement. So this is the pleural line sector, and this is how it appears. So this is a regular pleural line, first of all. Regular pleural line, what does it mean? It means a pleural line that is not too much thick and not too much thin, and particularly that is not discontinuous, interrupted, okay? So a pleural line of this thickness, homogeneous, finally homogeneous, is a regular pleural line. When it's not regular, for example, when you have RDS or superficial pneumonia or a very severe pulmonary edema, the pleural line will be thickened and discontinuous, dishomogeneous. Okay? What about the dynamics? I can have at least 4 patterns. One pattern is sliding sign, lateral movement. One pattern will be lung pulse, no lung sliding, but just pulsation. And one pattern will be nothing, no sliding and no pulse. Then we can have some variable we'll mention later. So here how I would describe this picture for the external part and the pleural line. No lines in the explore region, regular pleural line with sliding sign. Do you agree? This is the sonographic description. What is the physiopathological meaning? No subcutaneous emphysema, lung not collapsed by free air, first of all. Why? Because if the lung is collapsed by free air, I cannot see any sliding movement. So if I see a sliding movement, no collapse by free air. So no pneumothorax. So I can say the lung is not collapsed by free air. Neither by free fluid, otherwise I would see here an hypoechoic dark or black area in what is the pleural interface. So I can say that this lung is not collapsed by free air, neither by free fluid. What else? This lung is mobile, then is likely to be ventilated. So I would say lung not collapsed by free air, not collapsed by free fluid, and mobile. I would not say still ventilated, but at least mobile. What else? We'll observe what is beyond this in a while, okay? How it does appear in the M mode. You remember before Dr. Cheng showed you, this is the seashore pattern. This is straight, so skin subcutaneous are straight along the time in the M mode modality, and whatever is below the pleural line is granular, sandy-like. That's why we call it a seashore sign. So what in the D mode by dimensional view is the sliding sign. In the M mode, just this picture is seashore sign. So seashore sign and lung sliding have the same physiopathological implication. The lung is mobile and is not collapsed by free air. Okay? So no pneumothorax and no dysventilation, to be clinically clear. What happens when there is no lung sliding? Here you see the pleural line has not a clear lung sliding, but there is just a lung pulsation. You see? Tick, 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 tick. thick. So no lung sliding plus pulsation of the lung is described as lung pulse. Sonographic description, lung pulse. What is the physiopathological meaning of the lung pulse? The lung still is not collapsed by free air, otherwise I could never see the lung pulsatory. Okay? So if I see sliding or pulse, the lung is not collapsed by free air. No pneumothorax is there. If I don't see any dark or hyperechoic, black area in the pleural interface, no fluid there. So no intrapleural air, no intrapleural fluid here. But the lung is mobile or immobile? Immobile. And then probably is not ventilated properly. Okay? So lung sliding, no, as we saw before, not collapsed by free air, not collapsed by free fluid, and mobile lung, probably ventilated. Lung pulse, again, no free air, no free fluid in this image, but immobile lung. So here could be, for example, right lung intubation. You will have a right sliding present and absence of the lung sliding in the left side with the lung pulse, for example. But in both sides, no pneumothorax. This is how it appears in the M mode of the lung pulse with these pulsatile artifacts on the straight background. So it's not anymore a sandy pattern that we call seashore, but it will be a lung pulse pattern. What about the absence of the two? Here in this picture, you see that there is no lung sliding, no lung pulse. And there is a straight pattern that we call stratosphere sign in the M mode. What does it mean? Essentially pneumothorax in this case, because I cannot see the sliding, neither the pulse. If the lung is mobile or not, I don't know, because I cannot see it. So don't describe anything else, because we really don't know what is beyond the pleural line, the pleural barrier. What about the pattern beyond the pleural line? So what is appearing here? I'm going forward. This will describe maybe better later. This, sorry, I just missed is a sign that is in the border of the pneumothorax. You see here that here you can see the lung sliding, and here there is not the lung sliding. If this is consistent clinically with the pneumothorax, this will be exactly the border of the pneumothorax. So we could presume the extension of pneumothorax looking at this kind of artifactual appearance of what we call the lung point. The last few minutes just to tell you about the subpleural sector of the image. This is what we are pointing now. We already recognize that there is no E line, regular pleural line with lung sliding. Do you agree? How we call these lines, you remember? A lines. So hyperechoic horizontal lines are A lines. So no E lines, regular pleural line with lung sliding and A lines. This is the sonographic description. What about the physiopathology interpretation? No subcutaneous emphysema, lung not collapsed by free air, not collapsed by free fluid, mobile and dry, because there is air, just air in the lung. And I know that this lung is dry, so no pulmonary edema is there, no RDS, no superficial pneumonia, no pulmonary fibrosis that will create other pattern than this dry pattern. So the septa are not thickened and the alveoli are dry. What is happening when the septa are thickened and the alveoli are wet? You will have vertical lines, hyperechoic line appearing. You see that they are different from the E lines because the E lines were born from the chest wall to the bottom. But these, you see, are originated by the pleural line to the bottom. So these are lines that are coming from the reverberation of the ultrasound waves within the septa that are thickened or within the alveoli, thanks to the presence of extravascular water, more than physiologically present, or a diminished presence of air. So, whatever is the pathology that is reducing the air, like this ventilation, or increasing the extravascular water, like a pulmonary edema, you will have B lines. So, how we should describe this sonographic image? No E line, do you agree? Pleural line is regular or irregular? Here is irregular. You see that it's thickened and irregular. So you will say irregular pleural line with sliding sign that is present, and B lines, suggesting what? No subcutaneous emphysema, lung not collapsed by free air, neither by free fluid, with wet lung or disventilated lung, according to the clinical condition. This is how the thickened septa and wet alveoli are originating the vertical line instead of the horizontal line. What happens when alveoli are full of fluid? Then you will have areas that will become hypoechoic, dark, tissue-like. You see that you have not anymore A-lines, B-lines, but just these hypoechoic areas that will represent consolidated portions of the lung. You see the continuous A-lines, pneumothorax or dry lung. Then B-lines, disventilated or wet lung, merging B-lines up to have a white lung severely disventilated and or wet lung. And then if you have a lung full of water, it will become dark, hepatized, tissue-like. This is a full consolidated lung, not just a little portion. And this is how the fluid will appear, okay? So in this initial lecture, I just starting presenting the basic semiotics and signs to recognize air and fluids within the chest wall at the pleural interface level or within the lung or within the intrapleural cavity. This afternoon during the workshop, with the help of other slides, I will show you different pathologies accompanying the different signs that we'll be testing together. Okay? Thank you very much.